and trained number of people and started the interest of hemodynamics in many of the fellows like me. So we welcome Dr. Patrick Mcnamara, and over to you, Dr. Mcnamara, for your like right drug, which is the right drug to be used, and stage is yours, please.
Mohit, thank you for the wonderful introduction. I just noticed a message in the chat about sound. Are people able to hear me okay? Could someone give me a thumbs up or just to make sure?
We are able to hear you, sir. There
Yeah.
must be a individual problem, connectivity issue.
Okay, perfect. Okay. So first, let me thank Manoj and Professor Kumar, Dr. Verma, and others for this wonderful introduction. Although it's early in the morning, I'm more than happy to interface with this particular group. Obviously, Mohit is a person who is close to my heart, and I just hope his wife didn't hear that comment, Mohit. With respect to the most important person, I think I'm probably second maybe to your wife. Definitely not number first. Um, but I want to hopefully share some thoughts that I've certainly learned over the last 10 to 15 years with respect to this particular topic. And I think Professor Kumar summed it up very, very nicely. This is not so simple, not so straightforward. Unfortunately, in neonatology, we've tried to make it simple. And there are things in the practice of medicine that really should require us to think outside the box. And I think the field of hemodynamics is one of those specialties where you cannot get away from thinking about physiology. You cannot get away without thinking about precision. And it's highly unlikely that the answer to the question will be in the randomized controlled trial. So 3 years ago, I moved from Sick Kids Hospital in Toronto, where I spent the prior 15 years building this concept of hemodynamics. But I came to a program that had the most exceptional approach to care of infants at the limits of viability. And if you look at the graph on the left-hand side, what you can see is data from Iowa, which is an 87-bed NICU, compared to the rest of the Vermont Oxford network. And what's very striking is if you look below 25 weeks gestation, and particularly at 22 and 23 weeks gestation, there's this incredible survival rate with survivors up to 60% at 22 weeks gestation. And that came down to the attitude towards these tiny babies, two, the team and the approach to care, and three, precision. Now, in saying that, there were aspects of care, particularly cardiovascular care, that required refinement. And in many respects, bringing in the hemodynamics program really was, so to speak, the icing on the cake with respect to further advancements in care. Now, why is it important? Well, we're starting to learn from data in adults that preterm babies who were born kind of in the 1980s and 1990s are growing up to be young adults with heart disease, both hypertension, exercise-induced heart dysfunction, heart failure, and so forth, which really makes it incumbent on us to try to understand what are the prevailing risk factors in the neonatal period that modulate the risks of adult outcomes. And Professor Kumar's comment really was a segue in very much to this talk today. We have problems. We have many, many problems. And I think probably the foremost problem is that we provide care, but do we always provide the best care? To provide the best care, you need to have diagnostic precision. And in addition to this, there's oftentimes an imprecision in the choice of therapies and non-judicious use. How often do we provide a therapy, increase it, and continue to increase it without any positive effect? Well, if that happens, one is most likely to bias towards adverse effects of therapy without any positive benefit. So why do we do this? Well, I think parts of the problem is that we're still living in the past in many places. Publications like this from the early 2000s suggested that mean blood pressure above the gestational age should be the target of cardiovascular well-being, and recommending the use of volume followed by incremental doses of dopamine and so forth. Medicine is not so simple. Such a structure can be followed by anybody. You don't need to be a physician to be able to follow this type of an order. So we need to think beyond algorithms. Now, this is a recent publication from one of my colleagues, Reagan Giesinger, and it's very concerning. What you can see from this survey across academic centers in North America, Reagan asked the question, the approach to the care of infants with hypoxic ischemic encephalopathy. And what you can see, 17 different definitions of hypotension were reported. So people are confused, very, very confused with respect to how they define hemodynamic stability. So therefore, it's not surprising when we look at literature like this. This is some work from the United States, Bo Batten's group, which suggests or reported that babies who received treatment for low blood pressure were more likely to have worse neurological outcome or mortality, independent of disease severity. Now, this has prompted some investigators to say we should not treat low blood pressure. And I think that probably is an oversimplification. I believe blood pressure is important. The alternative way of thinking about this is perhaps the therapies used for treating low blood pressure were not the correct therapies. Some evidence that further adds to the fact that we probably are not thinking holistically is this work from Frank Van Bel's group in Europe. When you look at hypotensive versus normotensive patients, here on the top right, what you can see is that there really was no difference in neurodevelopmental outcome at 2 years of age. However, in the subcohort of infants in both groups who had low cerebral oxygen saturations using near-infrared spectroscopy, an impairment in neurodevelopmental outcome was seen, suggesting that it's not just about blood pressure, that there are other things to consider. So if you want to think physiologically about the relationship between hemodynamics and the brain, for example, one organ, and we'll come back to this later on when we talk about HIE, the following are important: blood pressure, cardiac output, vascular resistance, cerebral blood flow. Normal, low, high may be seen in each of these domains. However, our focus is just on a singular component. And this is way too simple. So why do we focus on blood pressure? Well, unfortunately, we still defer back to this publication in 1992 from the United Kingdom, which reported that we do not know what a normal blood pressure is. However, mean blood pressure is a guide. It's a guide, not the standard, not a scientifically validated threshold, a guide. Unfortunately, this guide has been translated into a dogmatic standard that is followed, not just in NICUs, but in PICUs, cardiac ICUs. People have no idea that we have not validated this threshold. So if you look at these two cases in front of you, I don't need to convince anyone that these babies are both very, very sick. The baby on the left has high blood pressure. The baby on the right has a normal blood pressure. So you may be critically unwell from a cardiovascular perspective, but have a normal blood pressure. And that gets to the relationship between blood pressure and cardiac output. As you can see, whether you're looking at left ventricular output or flow in the SVC, it's very clear the relationship is nonlinear, such that there are many babies who have low blood pressure that have adequate cardiac output. And of more concern, there are babies who have a normal blood pressure who may have a low cardiac output state. And these are the babies that worry me because we don't have a good threshold. When the blood pressure is normal or high, we assume cardiovascular stability. And there are many, many kind of assumptions that we make that may not be correct. So why are we in this mess? Well, we're in this mess because when we think of cardiovascular care, in many respects, we practice like general pediatricians or general practitioners. we provide symptom-based care. And symptom-based care may kind of help you to a certain extent. However, if you're interested in looking at how does intervention modulate acute instability to impact outcomes, it's very difficult when you have a whole range of therapies given for a whole range of symptoms. So for example, you may have poor perfusion and low blood pressure for which you give volume, pressors, and so forth. You can treat low oxygen saturations with mean airway pressure, surfactant, nitric oxide. You can treat metabolic acidosis with base. However, collectively, if we start to think of all of these symptoms not in isolation, the range of diagnostic possibilities to explain these constellation of symptoms is highly variable, ranging from ductal physiology to pulmonary hypertension. Therapies for PDA may harm patients with pulmonary hypertension. Nitric oxide given to patients with large PDA shunts will be harmed. So it's incredibly important to move beyond the symptom-based approach to a diagnostic-specific approach. So if we look at the following, okay, and this is the other challenge, we have this unfortunate reality in neonatology that we tend to localize symptoms to organs. So when we have patients who require respiratory support, we assume that this is a lung problem. So if we think of babies at 36 weeks gestation, okay, which is the outcome that we adjudicate many of our therapies, okay? And if you look at these three cases here, very similar, CPAP, 30 to 40% oxygen. And if you look at the echo, the septum is flat, the right ventricle is a little dilated. So you would say these babies look like they have BPD, perhaps with some elevated pulmonary vascular resistance, okay? The reality in these three cases here was very, very different. Case number one on the left-hand side had a large atrial septal shunt with QPQS that was over 2 to 1, explaining why this infant had need for respiratory support and why his right heart was dilated. Ultimately, we actually had to put in a device, the first time we've ever had to do this for this particular infant. The infant in the middle actually has got pulmonary vein disease. You can see here flow acceleration in the right upper pulmonary vein, okay, with a peak velocity of close to 3 meters per second. And then finally, the one that we're starting to pay more attention to is that there's a subproportion of infants who don't have pulmonary vascular disease due to lung disease, but like this echo here, you can see a very dilated left heart. And when we further explore this infant, the left heart diastolic function was very poor due to systemic hypertension. And this may be as much as 1/3 of our babies with BPD. So all of these infants have lung disease, but this is cardiac lung disease. And this is very important if we think now of how much we prioritize BPD as an endpoint to adjudicate therapies. We don't necessarily know it is true BPD. Our adjudication is based on receipt of respiratory support, which may be for many reasons. So we need to move beyond the status quo, which is very much an imprecise way looking at symptoms, blood pressure, oxygen saturations, to think about physiologically what's going on with these patients. And again, many people will have seen this slide before. You know, hemodynamics is about optimizing cellular metabolism, which requires ensuring that we have adequate oxygen delivery, which is dependent on hemoglobin, lung recruitment, and cardiac output, which is influenced by all of these loading conditions and so forth. Blood pressure is still an important symptom of cardiovascular well-being, but it's not the endpoint that you need to manage and treat at all costs. It's one measure of the adequacy of the situation. So over the last 15 years, we have been guiding the introduction of hemodynamics. And again, hemodynamics is not new. You know, for the last 50 years, ultrasound has been used kind of outside of the traditional setting. And one of the initial arguments, you know, why do we need this in neonatology? Well, last night I had the privilege of being invited to do a podcast across the pediatric Cardiology Network, which actually is the first time a neonatologist has been invited to speak on the topic of hemodynamics. But the reality is that when you think of the prior situation, you have a neonatologist who asks the question, and again, granted, physiology to a certain extent has died in neonatology. Our trainees are telling us from different programs, nobody is teaching us cardiovascular physiology. Our faculty don't seem to know cardiovascular physiology. So you have a person who has a question. A technician comes and takes pictures, and the report is generated by a cardiologist who looks at these pictures in his office. This model works very well for anatomic heart disease because the anatomy is going to be static. It's not going to change. If you want to appraise physiology, you need to understand, one, what's going on clinically? What's the fluid balance? What's the ventilation and so forth? What therapies is the baby on? Then you can make sense of dynamic, echo-driven physiological information. And not only can you use it to make a diagnosis, but you can use it to follow the patient. So in the around 2000, this first report by Nick Evans that up to 40% of NICUs in Australia were using echocardiography to guide care. And this was followed by a kind of a fairly strong publication by a cardiology group that reported, hold on here, this is not a good idea, because up to 50% of centers reported major errors. Now, 2 points. Number one, none of these echoes were performed by pediatric cardiologists, okay? Yet this was driven towards the neonatologist, which is very, very important in that when we train hemodynamic consultants, we're not training them to take pictures, we're training them to think physiologically. And we just published a paper just in the past 6 months reporting our experience with performing the first echo. And there were two main findings. Number one, the probability of an astute hemodynamic consultant in scanning the wrong patient, meaning scanning patients who have major congenital heart disease, is low. We're pretty good at identifying the patients that we should be scanning. Secondly, in those that we scanned, the incidence of missing any form of congenital heart disease was incredibly low. It was less than 1%. So around 2004 was the first hemodynamics club. You can see here, Isfan Seri was the chair, Nick Evans and Michael Weinlein. And at that point in time, they raised the concept that we need to think beyond blood pressure. And it's kind of a little sad that 16 years later, we're still trying to guide people to not be obsessive about blood pressure, to think of it more holistically. At that point in time, I had just finished my fellowship in the Echo Lab in Toronto. I had been doing cardiovascular research, and I came to the United States around 2005 and gave a talk about what we were doing at SickKids, and was told functional echo is not possible in the United States. It's never going to happen. That didn't stop me. And around 2005, we started to build our hemodynamics program at SickKids. And my vision was to make this program so strong, so comprehensive that nobody could question, nobody could argue that we are not training people to the highest level. And we built the expert model like any academy based on standardization, high quality, a culture of precision, okay? And recognizes the importance of the complexity of the physiology, the lack of mechanistic insight at that point in time, and being also conscious that there's a concurrent risk of congenital heart disease. Which then led to the 2011 guidelines, which really endorsed the concept that neonatologists can perform echocardiography as long as there were standards in terms of imaging standards in terms of interpretation standards. And I can tell you, 10 years later, we've now trained between 35 and 40 people. The quality of the individuals coming out of this expert model is exceptional. These are all names familiar to you: Amish Jain, Afif Al-Kafash, Reagan Giesinger, and others. These are people that are pushing the envelope scientifically. But the most interesting part of this is that even though they've done a year of training and they may have completed 500 assessments, they image incredibly well, but they have still questions about the physiology, which tells us that the only solution to building these programs is to train people to a high level. So now at the University of Iowa, where I'm privileged to lead, we have 22 faculty, but we have 5 trained hemodynamic physicians. Each have a different area of expertise. Okay, we've got 3 echo machines, and we perform over 1,200 consultations. This is our review room that we meet every day to review the cases. We now have 3 workstations here where people who are doing research can do their measurements and so forth. So it's really progressed significantly. But what is it all about? And why can echo help guide the necessary precision? Well, it comes down to 3 concepts that are incredibly important when deciding on therapies. First, a comprehensive knowledge of physiology. Secondly, having the ability to integrate the physiology within the clinical picture. And then finally, having a strong knowledge of cardiovascular pharmacology. And once you have these concepts, then with very comprehensive standardized echoes, and we do the same echo every time for every patient that has 75 to 100 images, longitudinal monitoring and so forth, one comes up with a concept of the hemodynamics consultation. The other thing, I want to share a case with you because I think it's really important that we recognize that this is an incredibly dynamic process. This was a 26-week infant who was outborn. Difficult delivery, there was head entrapment. This infant was somewhat asphyxiated at birth, got intubated, given surfactant, and as you can see from the x-ray, the lungs look pretty good. The baby was in room air. However, developed some low blood pressure for which he was treated with dobutamine. On arrival to our program, the infant continued to have low systolic blood pressure, was looking very poorly, had lactic acidosis. So we were asked to scan this baby. Now, if you think of low systolic blood pressure, the possibilities are diverse. You can give the baby dobutamine, or you can think what's going on physiologically. I reduce it to 3 simple concepts. The blood can't get into the left ventricle, the ventricle can't contract it, the blood can't get out due to elevated afterload. The causes are diverse, and to be able to identify specifically what's going on with precision to provide the most physiologically appropriate therapy requires one to be able to scan the patient. So when we looked at this baby here, and again, please don't worry about all of the details, the main finding was that the left ventricle was profoundly dysfunctional. You can see here the ejection fraction was only 40%, and this is LV strain analysis, which is an advanced way of assessing the left ventricle, was significantly impaired. It was about 50% of normal. The right ventricle was borderline, had borderline function. RV strain was about 15%, and this infant was in a low cardiac output state. So we asked the team to switch from dobutamine to epinephrine. Our experience is that if you're not responding to 5-10 parts of dobutamine, you probably are not going to respond. So rather than make the patient more and more tachycardic by giving them more and more drug that's not working, we transitioned to epinephrine. And then recommended they consider using vasopressin if the hypotension persisted. Over the next 3 hours, the infant had a neurological deterioration and ended up developing refractory seizures, which caused him to go into 100% oxygen. On epinephrine and vasopressin, his blood pressure stabilized. So having the tool in our hands, we went back and scanned again. Now what we can see is that the left ventricle is contracting normally, but the right ventricle, both the TAPSE and the right ventricular fractional area change are very significantly impaired. The right ventricular output is only about 30% of normal, and the ductal flow showed evidence of suprasystemic pulmonary hypertension. So now the physiology has changed from LV disease to severe RV disease with pulmonary hypertension. So we recommended to the team that they start him on nitric oxide, but based on our experience of using nitric oxide in extremely preterm babies, things change very quickly. And oftentimes the pulmonary vascular bed is incredibly vasoresponsive, such that right to left shunt may become left to right shunt, which may have significant consequences. And we advise people, if the postductal blood pressure drops after nitric oxide in responders, to think that this is probably means that we're changed the physiology and to wean the nitric oxide. And that's indeed what happened. You can see here on the left-hand side, the baby's blood pressure dropped to 31/16. They weaned the nitric oxide, and you can see immediate recovery in the blood pressure. When we scanned 3 hours later, you can see now the physiology has changed to ductal physiology with a large left to right shunt. And all of the other measurements confirmed that this was a high volume shunt. And I'm not going to be speaking about this today, but in our program, one of the things that we do to provide optimal care for tiny babies is we scan them all in the first 24 hours to target progressive PDA shunts as a means to minimize the risk of reperfusion IVH, which we believe is highly likely, like this baby, if you go from a low flow state to a high flow state as the ductal shunt progresses. So this is a very extreme case, but within 6 hours, the physiology has changed 3 times. And we can only provide optimal care by being able to accurately phenotypically profile the baby and provide interventions specific to this particular phenotype, which is important when you think about the diseases that we take care of. If we think of pulmonary hypertension in preterm babies, this is a study published in 2007 by the Buffalo Group. And if you look at this face value, these were infants who received nitric oxide because they were receiving a lot of oxygen. So therapy for a symptom. What you can see is that at the lower gestational age, the response rate to nitric oxide was much worse. There were more non-responders than responders, which may make you think that nitric oxide doesn't work in extremely preterm babies. That's not been our experience. We went on and conducted this study about 3 years ago in Toronto, looking at the relationship between nitric oxide response and echo-confirmed pulmonary hypertension. And basically what we found were 2 things. One, if you have pulmonary hypertension on echo and the infant was in the transitional period, the response rate to nitric oxide had an odds ratio of as high as 8. And this was independent of gestational age, which really emphasizes the importance of having the best information available to provide optimal care for these babies. This was further endorsed in a study we conducted, and the manuscript is under review, where for a period of 1 year in Toronto, we asked the clinician, when they requested us to do a consultation prior to the echo, they documented why they wanted the consult, what they thought was the diagnosis, and what would be their next step in management. We did not see what they documented. It was kept in a sealed envelope. At the end of the year, we compared what they thought to what the echo showed and what we recommended and what they ultimately did. And what you can see was that there was diagnostic and therapeutic discordance in up to 90% of cases for acutely unwell babies. The figure was less for non-acute situations like chronic pulmonary hypertension or PDA, but it was still significant. So even though in our best interests, we sometimes get it wrong. And this has happened to me at 3 a.m. I've made decisions without echo that have not been correct. So why is it important? Well, if you think of the following, and this is a philosophical slide, if your diagnostic precision is high, the balance is likely to weigh towards therapeutic efficacy. If diagnostic precision is low, the balance is likely to weigh towards adverse effects. And I think the best example of this in the neonatal literature are the trials of PDA. We have not well defined the population of interest, so we should not be surprised that the trials don't seem to show a difference. In studies, and kind of our group has just published something kind of late, in which you have better precision in selecting the right patients. And if your intervention solves the problem, the outcomes for these babies are vastly superior. So for the last part, I want to focus on some specifics. We'll focus on 3 areas. So first, preterm babies. So I think it's important to recognize that the transition is a period of significant vulnerability. There are major changes to both right and left heart loading conditions, changes in flow across shunts, and the heart-lung interaction is incredibly powerful during this period. First thing one needs to recognize about preterm babies is that number one, the heart of the immature infant is different. It's got less muscle, the muscle is less efficient, which makes it much more susceptible to afterload. Here's a case to emphasize one of our challenges. This is a 20-week, 8-week infant who developed low blood pressure. And this infant was treated with hydrocortisone. Now, if you look at the blood pressures here, where you can follow my arrow, they were initially low, mostly the systolic blood pressure. And after hydrocortisone, you can see the blood pressure recovered completely. However, the baby continued to develop metabolic acidosis and his lactate rose. So we were asked to see this baby. And if you look at the image, and you do not need to be an expert on hemodynamics to see this is the right atrium, this is the right ventricle. The right ventricle is not contracting at all. There's profound right ventricular dysfunction. This infant had incredibly low cardiac output state. So when we transitioned the baby to a therapy specific to what actually was going on, we gave him some milrinone with low dose epinephrine. We had complete recovery, which really emphasizes the importance of precision in selection of therapies. So how do you have better precision? Well, one, what is the disease? Secondly, what is the mechanism scientifically? And thirdly, how does the drug work? I would argue, and this is an incredibly important teaching point, not everybody has the ability to do comprehensive echo. However, there are some simple concepts that we can do to change and help better select our patients. Number one, okay, when we have low blood pressure, are there clinical signs of shock? If there are not, I don't believe we need to chase these patients aggressively. If there are clinical signs of a low cardiac output state, the next question we should ask is, what is the type of hypotension? If it is systolic hypotension, this is telling us that cardiac output is low, which may mean pulmonary hypertension or maybe as a result of heart dysfunction. Drugs like dobutamine, low-dose epinephrine are probably most desirable in this situation. If the problem is diastolic hypotension, okay, then one is thinking about vasodilator shock, hypovolemia, shunts like PDA. Again, providing a specific therapy for these situations to manage the diastolic blood pressure is important. The second thing, and this is a real problem, that we use the terminologies pressor, inotrope, as if they're the same thing. They're not. If you look at this table here, and again, I'm not going to go into any details about these drugs, but at one end of the spectrum, you have drugs like milrinone, which is a powerful vasodilator. Dobutamine is more of an inotrope with less vasodilator effects. At the other end of the spectrum, you've got drugs like vasopressin, norepinephrine, which are more vasoconstricting drugs. And then you've got drugs like dopamine or epinephrine, which may have a differential effect in respect to dosing. And that, to me, is always a concern because we may not have the ability to predict that effect. We don't have a lot of randomized controlled trial evidence, and I'm not sure if we need randomized controlled trials. I think what's more important is to look at disease-specific situations and look at choices of therapies and how they modulate physiology in those diseases, like what we've done with after PDA ligation. But again, what do? Not surprisingly, dobutamine increases cardiac output, but is not a good drug at increasing your blood pressure. Dopamine increases your blood pressure, but may not increase cardiac output. And that's a concern because our metric oftentimes to say we're doing well is, did the blood pressure increase? This study here from this Chinese group really emphasizes the challenges of using dopamine. What you can see here are two effects. Group A on the left, blood pressure increases, cardiac output increases. This is probably a desirable effect. The group on the right, their blood pressure increased to a much greater extent, but at the expense of cardiac output. And many people will say, well, these babies here probably got much higher doses of dopamine. Actually, they got lower doses of dopamine. So this for me is a concern because when you give dopamine, you don't necessarily know what is the effect, and you may not necessarily know that you may be fixing the blood pressure, but compromising blood supply to the bowel, to the brain, and so forth. What about pulmonary hypertension? Well, pulmonary hypertension is a disease that really has challenged people. And from one perspective, we oftentimes deviate away from what physiologically is going on. The disease is a disease of pulmonary vascular resistance, which which may lead to right ventricular failure. Our biggest problem is we stopped thinking about pulmonary vascular resistance, and we tend to obsessively worry about the blood pressure. And people oftentimes confuse that it's all about rising the blood pressure to a level that supersedes the pulmonary arterial pressure, which is not feasible. If your pulmonary pressure is 160, there's no way you're going to supersede that. So what I wanted to focus on today with pulmonary hypertension, there are some babies who do develop low blood pressure. How do we better provide them care to these babies? Most places, people will still use dopamine. And this talk is a little bit about why we need to move away from use of dopamine. The reality is we actually have got little to no evidence to say that dopamine actually does anything good. It's just become the thing we do. So how do we think differently about low blood pressure in infants with pulmonary hypertension? Well, the first thing you need to think that in essence, people used to term this as persistent fetal circulation. And to a certain extent, that's what it is. However, physiologically, everything results from the fact that we basically have a brick wall. Blood cannot get into the lung, blood cannot get back to the right heart, to the left heart, which leads to a low cardiac output state. So in thinking about better managing pulmonary hypertension, there are some physiological concepts we need to consider. Concept number one, the neonatal myocardium does not tolerate afterload. Afterload is what you do when you go to the gym, when you bench press, you put a load on the muscle. The graph on the left is what we call the stress velocity relationship. On the x-axis is wall stress. On the y-axis is heart contractility. The top graph is the newborn. The bottom graph is the older child. And what you can see is that the slope of the line for the newborn is much steeper, which basically means as you increase afterload, the neonatal myocardium does not tolerate that very well. Now, of even more concern is if you look at this relationship for the left ventricle and the right ventricle, what you can see is that the right ventricle tolerates afterload even much more severely than the left ventricle, which is very, very concerning when you're managing pulmonary hypertension. The higher the pulmonary vascular resistance, the more compromise you have to right ventricular function. The second concept is the force-frequency relationship. And at the University of Iowa and also in Toronto, we commonly get patients referred in for ECMO. These patients have a very classic phenotype. They're profoundly unwell, hypotensive, profoundly tachycardic, and profoundly hypoxic. And typically when we see them, their right heart is profoundly dysfunctional. In a normal heart, if the heart is functioning effectively, as heart rate increases, contractility should increase. This is called the force-frequency relationship. And eventually, with sustained tachycardia, contractility will fail. However, if you've got a blunted force-frequency relationship, meaning that the drug that you're giving to increase the heart rate is not increasing contractility, all you're doing is making the patient tachycardic and causing diastolic perfusion problems. So remember, the coronary artery is perfused during diastole. If you have tachycardia, your diastolic filling time is less. And that's what we classically see with these babies who are severely unwell with pulmonary hypertension. They're on massive doses of dopamine and epinephrine. The right ventricle is not contracting, and they're critically unwell. So it's important to recognize that there's a point at which the heart becomes decompensated. And in the setting of acutely unwell pulmonary hypertension, you have something called heterotopic adaptation, in which the right ventricle and the pulmonary artery are uncoupled. In the face of extreme pulmonary vascular disease, the right ventricle becomes more and more dilated and is profoundly dysfunctional. And in managing these babies, we got to look at ways to bring down pulmonary vascular resistance so that we can optimize and make it easier for the right ventricle to contract. Now, one of the problems is that in most centers, people have only subjective assessment. So when the pediatric cardiologist scans, they eyeball the right heart to tell you it's dilated or it's dysfunctional or the septum is flat. This is some data from a study we conducted in Toronto about 3 years ago, where we took 6 experts and we asked them to look at 60 echoes. 30 of them were healthy babies, 30 of them had pulmonary hypertension. And what you can see here is the kappa coefficient is incredibly low. Subjective assessment of right heart dilation, septal flattening, RV dysfunction is incredibly poor, which is why when we assess these infants with pulmonary hypertension, we look at them in a much more comprehensive manner, using multiple measurements to tell us about RV pressure, RV function, and the impact to cardiac output. So let me just give you an example of a case, just to emphasize how difficult it is and how important understanding the physiology is. This is an infant that was referred to us a couple of years ago, came in profoundly hypoxic, in 100% oxygen, nitric oxide of 20, was on an oscillator, had been started on dopamine. The dopamine was increased all the way up to 20. The baby became more and more hypotensive and his oxygen saturations fell. They then added in norepinephrine and epinephrine for low blood pressure, continued to be even more hypoxic. And as you can see, the blood pressure is fixed. They made the blood pressure go up, but the baby's tachycardic with incredibly low oxygen saturation. So he was referred to us, and this is the baby's echo. What you can see is that the right heart is profoundly dilated, the RV is dysfunctional, and the left heart is very small and underfilled. The ductus is small and restrictive with predominant right to left flow. So again, this phenotype, tachycardia with a normal blood pressure, with an OI of 54. So why do we have to be careful with selecting drugs? Well, here's some data from Keith Barrington's groups. And if you look at the effect of dopamine on blood pressure and cardiac output in the piglet model, all dopamine does when you give it to these babies is it makes their pulmonary pressure increase. Epinephrine may be slightly better in this model in that cardiac output improved, but it also increases pulmonary arterial pressure. So concept number one, why do we want to give drugs that are harmful to the problem that we're trying to treat? This was reconfirmed by this piglet study, or this is a sheep study, which looked at high-dose dopamine compared to dopamine with epinephrine. And what you can see that high-dose dopamine had some effect on blood pressure. The combination also increased blood pressure, but pulmonary artery pressure was increased much more significantly, such that the ratio of pulmonary to systemic pressure is in a negative direction, which basically means that this combination of therapies is actually not good for the pulmonary vascular bed. It's harmful. Some people have argued that maybe norepinephrine is better. There's some data from Satyan's group when he was in Buffalo, which actually showed that that's not true. In this fetal sheep model, increasing doses of norepinephrine in the presence of 100% oxygen lead to potent vasoconstriction. Concomitant administration of nitric oxide or superoxide dismutase seem to dampen the effect, but it's still predominantly vasoconstricting. This recent study conducted in the cath lab in pediatric cardiac patients actually shows that if you look at the relationship between these drugs, you get a very differential effect between norepinephrine, noradrenaline, and vasopressin. Here you can see systemic vascular resistance. Milrinone given, SVR falls, PVR falls. Following the addition of either norepi or vasopressin, SVR increases again in both. However, what you can see is that pulmonary vascular resistance remains low with vasopressin, but it increases with norepinephrine, suggesting that norepi is probably not the ideal first-line drug. So how do we provide better care for these infants with severe pulmonary hypertension? Well, our focus needs to be, how can we break down this brick wall? Well, we need to use pulmonary vasodilators. We need to give drugs that help enhance right heart function. And we need to ensure that the systemic blood pressure is normal but not try to target excessively high blood pressures. And then finally, maintain patency of the ductus. Milrinone is a very effective drug. To this date, however, there is not a randomized controlled trial. This is basically the work comes from our group, both here and the group in Dublin, showing that it does improve the efficacy of oxygenation and also improves heart function, both LV and RV function in term infants with pulmonary hypertension. It's a vasodilator. The problem is you cannot give milrinone to someone who's hypotensive, which means that we do need to have a drug to normalize blood pressure that will then allow us to give drugs like milrinone. So vasopressin is that drug. Systemically, vasopressin is a vasoconstrictor working through calcium channels. However, in the pulmonary vascular bed, it acts by stimulating enos and nitric oxide production to cause vasodilation. Data is still limited to case series, but certainly in our experience, vasopressin truly has been the magic drug to stabilize these babies, to normalize their blood pressure, to get them off drugs like dopamine, epinephrine that are chronotropic, and then allowing us to give milrinone. We talk about the MVP approach, vasopressin followed by milrinone. So what happened to this baby? Well, exactly what we said. The baby came in. We then switched him immediately. We stopped both the dopamine and norepi and changed it to vasopressin. We were able to immediately see improvement in the baby's oxygenation saturations. His RV function, however, still remained low, so we added milrinone, and the subsequent course was uneventful. This baby avoided ECMO and did incredibly well. So for the last few minutes, I just want to focus in on one setting that's related to pulmonary hypertension, for where knowledge of drugs like milrinone may need to be reconsidered. So the asphyxiated infant, and we oftentimes see these babies that become hypotensive, and many of them are being cooled. And this is a situation that's, I'm sure, very familiar to all of you, the infant of a diabetic mother who becomes asphyxiated, who develops pulmonary hypertension and looks unwell. And this is an important patient population because it really emphasizes the benefits of echocardiography. There are three physiologic settings that we see in these infants, the IDM babies who are unwell. Situation on the left-hand side. Due to therapy itself and oftentimes overuse of intrathoracic pressure, you can see here that this baby's left ventricle cavity is completely compressed because there's very little pulmonary venous return. This infant needs his wean airway pressure to be weaned. The baby in the middle, again, from the long axis view, you can see the right ventricle is not contracting. This infant needs a positive inotrope, dobutamine, potentially low-dose epinephrine, and potentially prostaglandin to open the duct if it's restrictive. And then the final group, which is the one that I really worry the most about, is the infant who has got hypertrophic cardiomyopathy, big hypertrophic heart, particularly septal hypertrophy that we oftentimes see in IDM babies. These babies do not tolerate anything that increases their heart rate. So any drug, dopamine, dobutamine, epinephrine, vasodilators are also not good. These babies require volume, and vasopressin is a very good drug for these babies because it improves their systemic blood pressure and helps fill the heart. So how do we provide better care for hypotensive babies with HE? Well, first, as we've just shown you, identify the physiology. Like everything, preterm, pulmonary hypertension. Again, this from Reagan's paper, dopamine is the first line standard of care, despite the fact that there is research that dopamine administration is associated with a worse outcome in terms of the risk of death or abnormal MRI. Okay. What we don't know is this cause or effect. Is it that infants who need treatment for low blood pressure are more likely to do unwell, or is it that dopamine is not the right drug? At least we need to ask the question. Some evidence that may suggest that perhaps dopamine is not the right drug comes from this study we published in the Blue Journal about 2 years ago, in which Reagan Giesinger conducted a comprehensive assessment of a cohort of 53 babies with severe HIE who were cooled. All these babies had multiple time point echoes. They were on continuous NIRS monitoring, cardiac output monitoring, EEG monitoring, and we were particularly interested in the relationship of heart function to neurological outcome because it had been our clinical experience that the worst babies seemed to have severe right ventricular dysfunction. And what Reagan actually showed was that the presence of isolated severe RV dysfunction predicted abnormal neurological outcome with a high sensitivity and specificity. Okay, the LV was normal in these patients. What was most interesting was that this effect was independent of HIE illness severity. So this does not seem to be just about worstly asphyxiated babies get bad RV dysfunction. There's something about RV function and its impact on cardiac output or therapies for it that may be modulating these outcomes. This is a subsequent study that looked at what happened clinically to these patients. And what you can see is that if you compare the babies who were treated with drugs for low blood pressure, you can see that by 24 hours, their blood pressures were comparable to patients who did not receive treatment. However, in the inotrope treated patients, there still was evidence of subclinical RV dysfunction and abnormalities of cerebral blood flow, which suggests that perhaps we're not choosing the right drugs or we're not optimizing RV function adequately for these particular babies. We subsequently have gone on and looked at the neurodevelopmental outcome at 2 years of age, which reconfirmed that those babies with bad RV function, not just only do they have an increased risk of mortality and abnormal MRI, but they're more likely to have abnormal neurodevelopmental outcomes at 2 years of age. The final comment I want to make is milrinone is a drug that I lauded for its role in pulmonary hypertension. However, in the setting of HIE undergoing cooling, we have stopped using milrinone. And we've done that for this reason. Here's a cohort of 3 situations. If you look at the graph here, infants who are in the green boxes are infants who had HIE with pulmonary hypertension who did not receive milrinone. You can see their systolic and diastolic blood pressure are stable. Their inotrope score is stable during the first 24 hours of life. The triangles, the purple triangles, are babies who had pulmonary hypertension but were not asphyxiated and cooled who received milrinone. You can see stable systolic and diastolic blood pressure with a low inotrope score. Now, what about the babies with HIE undergoing cooling with pulmonary hypertension who got milrinone? You can see a very dramatic early reduction in both systolic and diastolic pressure. And even though we stopped the milrinone, their inotrope score continued to escalate. And this may make sense because milrinone is a drug that's metabolized by the liver and cleared by the kidneys. And if you're being cooled and you're asphyxiated, we need to be very careful with this drug, that toxic levels can be risen significantly. So finally, what about training? Well, we have a 1-year fellowship, which involves individuals spend time in the Echo Lab and then time with us, in which they get comprehensive assessment. These individuals will complete somewhere up to 500-600 evaluations in that particular year, which helps us train people to a very high level. This is North America in the year 2021. Go back to 2005 when I was said this would never happen in the United States. Well, this is it. It has happened. Over the last 10 years, there have been over 600 publications to help us understand knowledge of normative data, imaging techniques, disease mechanisms, and so forth. So the field is ripe. It's growing significantly, and the expert model is generating these scientific thought leaders. There are programs now all across Canada as the standard of care, and increasing numbers of programs in the US and other parts of the Americas. We have a standardized diploma now for this. Some of our programs are formally accredited, and we're starting to build a hemodynamics research center for inter-institutional collaboration and educational initiatives. We have our bi-monthly Pan-American Hemodynamic Collaborative webinars, which are all hemodynamic webinars. If people are interested in, they can reach out to me. Finally, our group is now affiliated with the American Society of Echocardiography as a specialty interest group in neonatal hemodynamics. And I would encourage anyone that is engaged in hemodynamics in any way should become a member of this specialty interest group, because this is the future of the field. We're planning to update the 2011 guidelines, and there's a lot more exciting things that are happening within this particular group. But certainly this is a testament to how far we've come. So in conclusion, and I apologize, I've gone on a little bit longer than expected. A blood pressure centric approach is too simple. If we are to select, as in the title, the right drug at the right time in the right patient, you need to understand what is the disease diagnostically, what is the mechanism, who is the patient, what's their developmental situation, and what's the physiology. Finally, what is the pharmacological appropriateness of the therapy you're providing. Comprehensive hemodynamic evaluation may really help you provide not just care, but the best care. And then finally, there is no role for treatment nihilism. There's no sense that the duct should never be treated or blood pressure should never be treated. This makes no physiologic sense. It's about identifying the right patients. And on the counter, non-judiciousness. Next time you have a baby who has low blood pressure and you keep increasing the drug and the blood pressure is not improving, ask yourself the question, maybe I should stop that drug. Thank you very much.
Thank you, Patrick. That was really wonderful. I think what is very obvious is, as Dr. Patrick has demonstrated in the last 1 hour, he has worked from the bench to the bedside. So he has in-depth understanding of the physiology, pharmacology, and obviously the cardiovascular physiology. I think one very important message which comes out from his presentation is that we should not be treating simply symptom-wise. Like you do not treat fever simply with paracetamol. You try to find the cause of fever and treat the root cause. Similarly, you don't treat cough with simply cough syrups or antibiotics. So similarly, we have been traditionally treating these symptoms as, the disease per se. Whereas what he has shown, this is much more complex. And we have to also look at the cardiopulmonary interaction. A lot of symptoms which are respiratory are actually due to the cardiac problems. So I think what I would do is start the ball rolling with some of the questions which are there in the question answer box. And then maybe after some time, Mohit can take over. So I can see a lot of questions already. Let me read out for you, Patrick. Yeah, so there's a specific question from Dr. Kalyan regarding the case you showed, the 26-weeker with LV dysfunction and hypotension. What is the rationale of adding vasopressin? I think you already alluded to that, but maybe it needs a little more emphasis, because the worry people have is, would it not increase the afterload and worsen the LV dysfunction?
Yeah, so that's a great question. I think the fundamental answer to the question is, how do you support the left ventricle? And the speaker is absolutely correct. Increasing vasopressin to high doses, given it's going to increase systemic vascular resistance, would not be a good idea in terms of kind of increasing the afterload to the LV. However, equally, having diastolic hypotension compromises coronary perfusion. And the rationale in this situation was to give a small amount, low dose, which 0.3 is a very, very low dose, to at least maintain a normal diastolic pressure. The other rationale was what I would call anticipation. Okay, critically ill babies like this who have had a difficult birth situation are at higher risk of pulmonary hypertension. And I was expecting, yes, it looks like LV disease now, but we should be very prepared to recognize that the likelihood of a pulmonary hypertensive crisis is high in this baby. And that's exactly what happened. So we were kind of thinking ahead. I think one of the things about hemodynamics, I think that's important, is not waiting for the problems to happen. Okay, what is the risk and how can we modulate the risk? And that also underpins why we screen tiny babies between 12 and 24 hours. We want to know as early as possible, is there physiologic dysregulation? meaning is there subclinical heart dysfunction? Is there a ductal shunt that's progressive? And let's prevent that to optimize organ blood flow. If you think about, if you think of the analogy, sepsis, we don't wait for babies to have catastrophic shock before we give them antibiotics for sepsis. We look for early warning signs, thresholds. We prophylax babies based on a significant risk. There's no reason that hemodynamics should be any different to that. But the question is correct. One should be very, very careful with using vasopressin for pure LV dysfunction. Okay, if this was a very different situation, let's say it's a baby with isolated LV disease with no risk factors for pulmonary vascular disease, we would not use vasopressin for hypotension. We probably would go with epinephrine, dobutamine, and then once the blood pressure is normal, we would then probably add in milrinone.
Thank you, Patrick. The next question is from Dr. Ramakrishnan from Southern India, and he is specifically asking about non-invasive electrocardiometry. So he is using in his unit, and he's asking whether you have any thoughts about using electrocardiometry in conjunction with functional echo.
So it's a great question. We have used it scientifically in a number of studies. We looked at it in infants after PDA ligation. I think two things about it. Number one, it's a trend tool. It doesn't give you accurately what cardiac output is. However, there's a consistent bias. So we actually showed that the bias is around 30%, in which it underestimated true cardiac output by 30%. So I think to guide what's happening to cardiac output, I think you can use it. However, it's important to first correlate it with an echo, because it doesn't give you diagnostic precision. It doesn't tell you what's going wrong. It just tells you something may be going wrong. So where I would recommend, let's say, for example, the baby we just presented, you see that the left ventricle is dysfunctional and the cardiac output is low. You start a drug to support LV function, then you can use it to monitor, is the cardiac output improving after this, to reassure yourself that we're going in the right situation.
Yeah, maybe it sounds like using the transcutaneous PO2 or CO2.
Yeah, just like that, exactly. You're never going to, the PO2 tells you something is wrong, but it doesn't tell you what's going wrong. But again, I think if you don't have the ability to do frequent echoes, I think it's helpful to tell you what's going on. But I wouldn't use it in isolation of echo.
Yeah, wonderful. Dr. Amira is asking if INO is not available, which is a common scenario in many of our units. Are there any alternatives? I guess one specific question can be about sildenafil, but maybe some other drugs also.
Yeah, so I think sildenafil is not an unreasonable thing to give if you don't have nitric oxide. Obviously, it's working on the same pathway. Of course, milrinone also is a treatment for pulmonary hypertension. Obviously, with the caveats that the asphyxiated babies cooled are probably not the best candidate for milrinone. So I think sildenafil is very reasonable. Milrinone is very reasonable. They both are vasodilator drugs that can be used without nitric oxide.
Okay.
But the other thing just to mention as well is don't forget the simple things. Making sure the lung is well recruited, that you're ventilating well, that you're not causing any harm, because sometimes we can make pulmonary hypertension worse by increasing the intrathoracic pressure too high. So if you look at the relationship between PVR and intrathoracic pressure, at low mean airway pressure, if the lung is under-recruited, your PVR will go up. And at the other end, if the lung is over-recruited, you'll also increase PVR.
Yeah, I think I fully agree with you. We must look for preventable causes or modifiable causes before going on the drugs. There's a question from Dr. Kavya. Our older textbooks used to mention we can use very low dose of dopamine as a renal dose, and maybe it helps to improve the urine output and all. So any take on that?
Yeah, so this is a translated practice from adults. There's really not a single neonatal study to say there is or there is not this so-called renal delta dose. There's one large trial in adults maybe 15 years ago which actually disproved the concept. And I think probably where one might see a benefit, you see it pretty much with any drug. So, for example, when we use vasopressin, it seems counterintuitive, antidiuretic hormone. But for our cohort of babies with pulmonary hypertension, the administration of vasopressin, which led to recovery of blood pressure, led to improvement in urinary output. So I think it's all about renal perfusion pressure. So I think whatever the drug that you're using, okay, if one optimizes the hemodynamics, you're going to see kidneys working better. And that's a combination of a good blood pressure and a good cardiac output.
Thank you. There's a question by Dr. Tanveer. I think Patrick already answered that in case of PPHN with RV dysfunction, do we need to use PG1 to keep the PDA open?
Yeah, so let me comment on that for a minute. So one, there's two situations where prostaglandin is helpful. Situation number one is if the right ventricle is profoundly dysfunctional, okay, and you've got very low pulmonary blood flow. Opening the duct has two benefits. One, it offloads the right ventricle, but secondly, prostaglandin is a pulmonary vasodilator. So if you're in a program in India and you don't have sildenafil and you don't have milrinone, prostaglandin as a pulmonary vasodilator may be a therapy to consider. So again, but also be cognizant that it will drop your systemic blood pressure.
Okay. There's a question from Dr. Muhammad that if we do not have echo available and the preterm baby has a normal blood pressure but has metabolic acidosis and poor perfusion, how can I approach? And a supplementary question is there any role of bolus of normal saline? So I think maybe you can elaborate on this bolus issue because we are very fond of using repeated boluses of saline in any case. So
yeah.
you could elaborate on that.
Okay, so this is an important question. I take you back to the slide, and I think one of the manuscripts I would refer people to is Reagan Giesinger's publication in Seminars about 4 years ago, Approach to Hemodynamic Instability in Critically Ill Babies, where we talk a lot about choices of therapies. But in the absence of echo, okay, go back to that graph. Is the problem systolic blood pressure or diastolic blood pressure? That's the first question. If it is a systolic hypotension, it makes no sense to give volume because we know that the Frank-Starling law is flat in the newborn. Giving volume does not lead to an increase in contractility or an increase in cardiac output. So I would say if you're dealing with systolic hypotension, I don't see much of a role. Now, if it is diastolic hypotension, then the next question becomes, what's the physiology, or what do you think is going on with the baby? If the infant has gastroschisis, or there's loss of volume for whatever reason, a transitioning very preterm baby that has kind of got a lot of thermoregulation losses, you could consider giving a slow bolus of volume to see what's the effect. But if a single bolus of volume isn't doing anything for you, then there's no real logic to giving volume in that situation. Now, the only situation where actually volume is a very helpful therapy, in my opinion, is the infants with hypertrophic hearts. Because when the heart is hypertrophic, you have restrictive filling. So you need to maintain a high central venous pressure. And as we already said, giving drugs to increase the heart rate and contractility don't help those babies. Volume for the IDM baby with hypertrophy, particularly if you see on an echo that there's compromise to left ventricular outflow tract obstruction, then I think volume is very helpful for those babies.
Thank you, Patrick. Now, since you kind of gave us a lot of disadvantages of and adverse effects of dopamine, so is there any situation where you will use dopamine actually? Or we can discard it?
Yeah, I saw that, and I saw somebody else ask that in the chat question as well. So here's the deal, okay? If we have institutionalized dopamine, we've made it our standard. But if you actually go to the medical literature, there's not a single real report to say dopamine does something good. Okay, so that's our starting point. We don't have anything good. Now, when we think about, and that's why I've tried to reduce it to what are the physiologies and then how do drugs work, okay? Pulmonary hypertension, PDA, heart dysfunction don't make sense to use dopamine. There are other drugs that have biological effects, and and we've studied that milrinone is a great drug after PD ligation. We've studied that vasopressin is a very good drug in pulmonary hypertension. Okay, where might dopamine be helpful? Septic shock. I think in septic shock, I think there is a clinical situation where we would use dopamine, or we may use norepinephrine. But outside of that, it's very hard to find a situation where the biology of the drug makes sense. And again, my biggest concern is that it's not a clean drug. You cannot predict what's going on. The reality is, for most people, people have accepted it because if the blood pressure is low, it makes it go up. Okay. And that, unfortunately, is oftentimes how we think. We try to fix symptoms, and fixing symptoms doesn't necessarily help. And if we look at centers that have a high rate of ECMO use, they all use high doses of dopamine. We never use dopamine. We never have ECMO. And I firmly believe that one of the reasons perhaps why the trials of nitric oxide in congenital diaphragmatic hernia never showed a difference was because probably those babies were getting massive doses of pressors that were counteracting the effect of nitric oxide.
Okay. Dr. Rangaswamy is commenting, dopamine is a promiscuous drug, really. Yeah. So before I hand over to Mohit for continuing to ask you questions with a long list of questions, maybe one last question I can read out. Can we use dobutamine in PPHN if blood pressure is borderline for poor contractility rather than milrinone?
Yeah, no, I think dobutamine is a very reasonable drug. Okay, and as I said, I think whether it's dobutamine, whether it's epinephrine, I think one of the most simple concepts that we need to ask ourselves is, if you're giving the drug, are you getting the desired effect? And if by giving more and more of the drug, there's no benefit, why we continue it? We have this habit of increasing things to the max, and then we go to the next drug. We don't say, stop that first drug. We go to the second drug, just add on and add on. And that's basically why many of these babies end up kind of profoundly unwell as ECMO candidates. Milrinone is a great drug in pulmonary hypertension if you have a good blood pressure. That's the first thing. And you're not asphyxiated. Dobutamine, I think, is a very reasonable drug to support the right ventricle in hypotensive babies. Sometimes I would choose dobutamine if the blood pressure is kind of borderline. If the baby's very hypotensive with RV dysfunction, I may use low-dose epinephrine just because it's going to give me some alpha effects on the systemic vascular bed. But there's nothing wrong with dobutamine. Where I can tell you my experience, it's very rare the baby that you give more than 10 mics of dobutamine and you see some positive benefit after 10. For me, if there's no benefit by 10 mics, I'm thinking of something else.
Thank you. Thank you. Mohit, maybe you can continue the rest of the question.
Thank you, sir. Great presentation, Dr. Patrick. Just in continuation with your last, Dr. Sorek, he is asking, like he or she, I don't know, like this person is asking, what is the low dose epinephrine? How you define, like, what is the low dose epinephrine? So
Yeah.
Doctor wants to know.
So most people would classify low dose epinephrine as kind of probably less than 0.5 to a maximum 0.8. I think what you're getting close to 1, or 0.05 and 0.1, less than 0.05, I would classify as low dose epinephrine.
Oh, okay.
The other thing that's important with epinephrine to recognize, and where oftentimes as you increase the dose, you get this effect on lactate and glucose utilization that sometimes can be harmful. Or I can tell you one very interesting baby that we had with this was a severe myocarditis patient due to enterovirus that had profound left heart dysfunction that didn't matter what the drug that we gave. As we increased the drugs, the infant continued to get lactic acidosis. We ended up using therapeutic hypothermia to actually decrease metabolic use of the myocardium to actually stabilize the hemodynamics. I've just done that once for 24 hours and it helped stabilize that baby. So that's a bit radical. Please don't go start using therapeutic hypothermia for LV dysfunction, but in that unique situation, it worked.
So, Dr. Binay, he is being asking how to chase the blood pressure, and like he wants to know what is the cutoff value for to define hypotension in extreme preterm babies.
So all I can tell you is what we do here. We use mean blood pressure and gestational age as a guide. However, as I mentioned before, if it's below the gestational age, we don't chase the blood pressure. The other thing to remember is that where you're measuring blood pressure is also important. Okay. So, for example, preterm babies, we measure it through the UAC. If the physiology is all left to right shunting across the ductus, okay, the postductal blood pressure will be low. The preductal blood pressure may actually be much higher. And that may be one of the clinical clues of a large left to right shunt. So that's where one has to be very, very careful of chasing transitional mean blood pressure less than gestational age if the baby looks well. Now, if the blood pressure does not look well, or if the baby doesn't look well with a low mean blood pressure, and there's metabolic acidosis, poor urinary output, then, as I mentioned, using the systolic and diastolic pressure to choose what are the threshold, the therapies to give, which basically means that people need to know the centiles. There are centile charts where you can identify the third or the 10th percentile to be able to track. And if anything, for people that don't have echo, think about systolic and diastolic blood pressure. Think about where you're measuring the blood pressure. And on the counter, in babies with severe pulmonary hypertension, you may assume your blood pressure is normal postductally, but preductally, in the presence of a right to left shunt, you may actually have preductal hypotension. So measuring forelimb blood pressures is also something we need to start thinking about in neonatology.
Yeah, so that is very important. That you have always taught us. So this is one common question many people are asking, like how they can join your hemodynamics webinar.
So um, we have um, we have a link, and I'm happy to share the link to the webinar to Manoj or to anybody here to disseminate it. I'm not sure if you have a network of email addresses that go out. I can certainly, rather than try to add everybody to our group, we would just have the link disseminated. We do this every 2 months, and I'm more than happy to share with you, Mohit, or to
Yeah,
whoever's organizing this. Whatever way is most efficient, we were happy to do that.
sure. I think so. You can share it with Dr. Manoj, and then we can take him from there. I
Sure,
think so.
no
It will
problem.
be good.
We,
Yeah,
we will share the link.
sure.
Okay, that's fine. Yeah, yeah. We have an interesting talk coming up on March the 17th on which I think is one of the future of neonatology, which is predictive analytics and artificial intelligence, the use
Wow.
of these comprehensive systems, and we've got something called SickBay, which gives us uh, real-time data that stream 2,000 data points per second, in which kind of one of our investigators is looking at these tiny babies, and they're monitored with cardiac output monitoring, EEG, kind of every monitor to look at how can we better predict abnormal patterns.
Great. There's someone who is asking like when you will use norepinephrine in hypotensive condition. In which condition you would use norepinephrine?
Yeah, so I can tell you of two situations we use norepinephrine. So one is, again, in septic shock. Okay, we will either consider dopamine, norepinephrine, vasopressin in septic shock, depending on the clinical parameters of the babies. But norepinephrine is a very good drug for septic shock. The other situation is in recovering babies with pulmonary hypertension. So while vasopressin is a good drug, you have to be incredibly careful about salt and water balance. Okay. Once the sodium starts dropping, because it will drop with vasopressin, we don't wait for it to drop to less than 135. We start increasing the sodium once you get close to 135. Okay. Um, the second caveat with vasopressin is that when you stop it, some of these babies develop significant polyuria. So you have to wean it off slowly. And we drop it down typically to a dose of 0.01 before we stop it. So very, very low dose, and then we stop it. But if we have a baby who's stuck on vasopressin and they're having salt balance issues, we may then transition them to norepinephrine so that we can facilitate getting off vasopressin. I think given norepinephrine in pulmonary hypertension, when the FiO2 is less than 60%, is probably okay. It's just in our experience, babies who get norepi and in 100% oxygen seem to get much more vasoconstricting effects. But at lower oxygen, it's probably okay.
Okay. Dr. Muhammad is asking, like, if he has already started the baby on dopamine and then they have added on the epinephrine, so should we continue the both, or should we wean the dopamine once they have started epinephrine?
Yeah, so again, it goes back to this. We talked about this a little bit earlier on. If you've given dopamine, doesn't matter what the drug is, and nothing good has happened, then it makes no sense to keep the drug. Okay? Why would you keep something that's not helped? You're just biasing everything towards the adverse effects of therapies. So again, if the problem is hypotension, okay, and let's say it is diastolic hypotension, and you've given dopamine for septic shock, for example, and it has not improved, then it's reasonable to think of a different drug, norepinephrine, epinephrine, vasopressin. And I would stop it. Personally, I would stop the drug. I would stop the thing that's made no difference. But you got to be sure that no good has happened from the drug before you stop it.
Okay. This is a question by Dr. Victor. Dr. Victor from Peru. What his doctor is asking, like, they don't have nitric oxide or milrinone, but they have levosimendan. So, like, he just wants to know your experience regarding pulmonary usage of levosimendan in pulmonary hypertension.
Okay, so very simple answer. My experience is zero. We can't get levosimendan in North America. I wish we could. I wish I had levosimendan. I think it makes a lot of sense. So for people that don't know, it's a ryanodine channel blocker. It works through calcium mechanisms. So for severe heart dysfunction, I think it would be very, very important to use this to support severe right ventricular dysfunction. What I don't know is what's the effect on the pulmonary vascular bed. Theoretically, it's felt to be have a little bit like dobutamine, have weak vasodilator effects. So, I think levosimendan is probably a better dobutamine. That's my thoughts on it, but it's not from personal experience, and I wish I had levosimendan.
Great. So there is one question. This is just regarding for nitric oxide. Like, Dr. Ahmed is asking, is it safe to start nitric oxide in preterm babies less than 30 weeks?
So I think there's two potential indications for nitric oxide. One is its use for acute pulmonary hypertension. The second is its use to prevent pulmonary vascular remodeling, BPD, and so forth. Okay. Let me comment on both of those situations. So firstly, as an acute agent, as you've seen from our data in Toronto, it is effective as a pulmonary vasodilator in babies who have confirmed pulmonary hypertension. That piece is clear. But we don't necessarily know what's the optimal starting dose. In the case I mentioned, the clinical team wanted to give 20 parts of nitric. Personally, I use between 5 and 10 parts. I try to use the lowest I can because my personal experience is that in the babies in whom it works, it tends to work fairly quickly, and we've been able to get it off quickly. And I think based on the hypothesis that if the ductal shunt is open, the infants with pulmonary hypertension have a low cardiac output state. If you bring down your PVR quickly, you're going to increase the left to right shunt across the duct, which is going to increase cardiac output, which is going to increase the blood flow to the brain. And that may be one of the reasons why in the early days of some of the nitric oxide trials, there was an association with IVH. So we give it only with echo confirmation, and we wean it off quickly. That's certainly our approach here as a hemodynamics program. The question for chronic use as a kind of a BPD prevention, pulmonary hypertension prevention, the evidence is much more confusing. The problem is that the trials that used prolonged targeted therapy didn't use, in my opinion, good enough selection criteria. So for example, if you have a baby that's ventilator dependent due to large left to right PDA shunt, the worst thing you can give those patients are nitric oxide. Those babies were not excluded from the trials of prophylaxis. So I think a day will come that we may revisit this and look at low dose therapy. We have used it in select patients with a closed duct who are getting progressive pulmonary vascular disease at a very low dose of 5 parts to try to prevent worsening BPD, pulmonary hypertension, and it seems to be doing something. But that again, that's just anecdotal clinical experience. For now, I think we have to wait for better studies to define the indication for preventative use of nitric oxide. But for acute use, I think if you've got an infant with hypoxemic respiratory failure and you have nitric oxide, my suggestion would be get an echo. If you confirm pulmonary hypertension, it's okay to use nitric oxide, but use it at a low dose and wean it as quick as you can. That's my suggestion.
Somebody is asking like what will be the indication to add on steroids in hypertension, when it should be added steroids?
Yeah, so the steroid approach. So I presented I presented a case which was for one reason, is for me, hydrocortisone, it should never be a first line therapy for hypotension. Because if you don't know what's going on physiologically, you can fix the blood pressure, but not fix the problem. Okay. So I think one where I use hydrocortisone is in situations where I think it makes biological sense. So for example, infants who present with septic shock, with neck, I would use hydrocortisone early. Okay, if the baby's not responding to a single drug for hypotension, I would start hydrocortisone. In babies that have meconium aspiration syndrome, I also, independent of blood pressure, I would use it as a anti-inflammatory agent for lung disease. There's some animal data that suggests it's helpful. And then finally, there's some data suggesting that hydrocortisone may have some benefits in infants with CDH. But I think waiting to fail 3 pressors, you probably have waited too late.
This is Dr. Manoj. Should we continue or like it's 9 o'clock?
It's we are reached our time. It's up to Professor Patrick to because I know he has a long day ahead. It's night for us. It's early morning for him. So
I could maybe 5 minutes, 5 minutes more, and then I need to go.
Yes.
Okay.
Thank you so much.
Great. Praveen sir.
Yeah, Mohit, I think we can pick up few, because most of the questions are related to drugs and all, but maybe we can pick up few of the important ones.
Yes, sir.
So let us scan through and maybe.
Yes, sir. So somebody is asking, like, this is many times I have even people asked, like, if they don't have sildenafil and nitric, magnesium sulfate in PPH and usage of magnesium sulfate.
Yeah, it's a long time since I've used that. I remember 1995 when I was starting off in neonatology in the UK, they were using magnesium sulfate. Again, you know, it's if that's all you have, then that's all you have. Obviously, the challenge, of course, is going to be the diastolic hypotension that you get with magnesium sulfate. You know, as I said, prostaglandin to me, I think is a more logical therapy than magnesium sulfate. I would be more likely to use prostaglandin because by maintaining ductal patency, plus the vasodilator effect on the pulmonary vascular bed, I think those things would be advantageous.
So Patrick, there is a question from someone that apart from ultrasound, what are the other tools to determine adequate perfusion pressure? For example, can we use the perfusion index on the pulse ox or NIRS or something else?
Yeah, so I think yes. So some people have shown some nice data with the perfusion index, which I think is helpful. More information to me helps you make more informed decisions. I don't have a personal kind of experience with the perfusion index. The session on March 17th with this artificial intelligence is going to talk about some stuff with pulse pressure variability and its reliability also for assessing kind of systemic perfusion. I think we've already talked about non-invasive cardiac output monitoring can give you some additional insights. And NIRS, I think NIRS is important and gives you some clues that the organs may be suffering. However, there are also some caveats to NIRS. So for example, the infant who is asphyxiated, okay? If the brain is profoundly damaged, the brain is not going to utilize oxygen. So the NIRS of the brain will be high. They have high saturations. So in the setting of HIE, its use from a brain perspective becomes less useful. The second, in infants with large left to right PDA shunts. Okay, the literature on NIRS is very confusing and I think misinterpreted. If you think biologically, what happens if you've got QPQS that's 2-to-1 or 3-to-1, your cardiac output is going to rise. Okay, and that blood that's exiting the heart has got a high PO2. So the brain, which is perfused preductally, is exposed to a much higher amount of blood flow. Okay, and I think that's an important concept that we've kind of not thought very much about in neonatology. But the brain and the eye, in the setting of large left to right shunts, are exposed to more blood and more blood with more PO2. So kind of NIRS values in our experience in babies with big left to right shunt, acutely in the first 1 to 2 weeks of life, the NIRS value is high in the presence of a large PDA shunt. Now, after maybe 3-4 weeks exposure to a big left to right shunt, it's biologically plausible that you get remodeling of cerebral blood vessels that increase cerebral resistance. I think then things may change. But in the first 2 weeks of life, I think it's not likely to be helpful.
Okay. One very basic question being asked, whether I must have an invasive BP if I'm using these drugs or non-invasive BP is good enough.
I think if you have non-invasive blood pressure, like invasive BP is not perfect either. Like sometimes we have cuff, we don't have invasive things that work. The lines eventually become less functional. So I think as long as you've got an appropriately sized cuff, okay, then I think there's nothing wrong with using non-invasive blood pressure.
Wonderful. And there are a few questions regarding your one-year fellowship program. So people are asking how they can join or are they eligible. So maybe you can refer them to some site where they can go through the details.
Let me just share something for you. Okay, so there's if anyone wants to look at details of our fellowship program. Now, again, coming to North America in the United States comes with all the need for doing US exams, US MLEs, and all that kind of stuff. So it's not so simple. Okay, it's not impossible, but it's not as easy as perhaps when we were in Canada. But there are also some great programs in Toronto, Vancouver, etc., that do something very, very similar to this. But I think, also, you've got some great people in India, and there's no reason why, and I would appeal to the community in India and other countries to look locally at setting up, at least in a single center, a center for excellence. Here's a program that will provide you a single year training. And then what that can mean is that people that do 1 year training there could come for visits to North America. They don't have to go through all the complications of credentialing and everything. Plus, as well, we only have a couple of spaces per year, and we tend to already be blasted with people that are interested to do this. But this is the future of neonatology. We need to be subspecialists. We need to have hemodynamic consultants, neurocritical care consultants, and then who all work together as part of a team. It's like I talk to people like when I coach soccer, you don't have a team of just defenders or a team of just goalkeepers. You have central defenders, you have wingers, you have a central midfielder, you have strikers. Neonatology should be no different. You want accumulation of expertise to provide the best care for babies.
Yeah, that's great. So, the National Neonatology Forum is working on this direction, and the group of active people who do this already have made some kind of framework how we can have a program of at least maybe 6 months, if not longer. Hopefully, in the next year or so, we would have something, and maybe the training program expand. So I think it has been a wonderful, yeah. Yes, Patrick, please continue.
I think you got to start somewhere. Again, I started off on my own at SickKids, and we built it slowly. And once you start to build some key programs, then those individuals will move to other sites and they'll start to build their programs and so forth, and then it disseminates. The one thing that I would argue against is mass dissemination with lots of people doing this in a very limited way. The strength of our program is based on the fact that it's a core group of people. We have not every neonatologist doing this, a small group of people who have a critical volume of experience, and they become the experts and the scientific thought leaders. If you dilute the expertise so much, the probability of misdiagnosis, incorrect decision making is going to increase significantly. So critical mass of people that are trained to the high level possible would be my comment.
I think I would endorse that viewpoint very much. We're already seeing it, that people are buying eco machines and attending a one-day workshop and starting doing ecos.
That is going to kill the field. It's going to kill the field. And
so
it's also,
I think it has been a
I'm just going to say, Praveen, that in the eyes of pediatric cardiologists who were they've been incredibly supportive of our program, but they will not look positively on broad dissemination without structure. It will not be positively seen.
That's right. Yeah. So I think it has been a wonderful marathon session. Patrick had really made a very, very complex and difficult topic sound very simple. But I'm sure when we try to go into it, it's not going to be that simple. But at least it's a stimulus. It's a sensitization that it's not simply doing an echo and trying to use drug A, B, or C, and really understanding the pharmacology, the physiology, the changes with gestation which happen, the cardiopulmonary interactions. So all that has to be really understood. And I think the good old days when in our fellowship program we were learning a lot of physiology-based, discussions, they need to be revived certainly. I think the only wish I now have is maybe in my mobile, if I can have a new app called Patrick, or maybe something like Alexa or Google, it simply answers my question. So I ask the question and I get the answer, because Patrick is only in one place, so we need him everywhere.
It give you a headache, though.
Wonderful, Patrick.
No. I want to thank everybody for the invitation today. It's an absolute pleasure. Like, I wish I could stay longer, but unfortunately I've got all this administration. The one thing I noticed on your first slide, we need to get someone from Ireland to attend your conference. There was no Irish flag apart from me. So that's going to be one of your objectives, to get somebody from Ireland to attend.
We will, sir.
Okay.
Thank you. So over to the host for